Good morning. I'm Jessica Lovell. Welcome to the Morning Medical Update. We all get sore throats. It's a very common symptom, especially in the middle of cold and flu season. But the woman we're meeting today says her sore throat did not go away. And in hindsight, that was the key warning sign that cancer was growing in her throat. Today, we are learning more about head and neck cancers, and we're going to ask how to tell the difference between a simple sore throat and a symptom of cancer. And we'll hear what it's like learning how to swallow again while healing from cancer treatment. But first, let's get to our morning rounds. New research from the CDC shows pregnancies are getting shorter. Full-term pregnancy is considered 40 weeks. The new study found early-term births, that is 37 to 38 weeks, are up 20% since 2014. Preterm births, meaning before 37 weeks, are up 12% in the same time frame. Full-term and late births dropped by 6 and 28% respectively. But helping us understand what's considered concerning about this information and kind of understanding what this all means is Dr. Mark Parrish. He's an OBGYN and fetal medicine specialist here at the health system. Dr. Parrish, good morning. This data seems concerning just from the layman's standpoint, because less time in the womb, we think, often means higher chance of complications. So kind of tell us what we're looking at with this study.
Hey, good morning, Jessica. Thanks for having me on today. This study, it certainly points out that we have earlier delivery trends happening. And as you mentioned up there, a full-term pregnancy is considered to be 40 weeks. We in our world consider term to be 37 weeks, but some people would use the term or use the early term phrase for that. The problem, obviously, there's two things here to take into consideration. Is what are the reasons for the preterm or early term births occurring? There are also, as you showed in that graphic earlier, we have an uptick of about 12% in preterm births, so births before 37 weeks as well. If we take a deeper dive into this, in the past, I would say beyond, we'll say 10 years ago, it was commonplace for OBGYNs, primary care physicians that participated in deliveries to deliver patients electively at 37 weeks and beyond because it was considered term. But what they were finding out was that there were consequences to these kids that were being born that early. Babies born at before 39 weeks, let's say between that 37 to 39 week mark, have a 3 to 5% risk of having some form of complication that could result in them being admitted to or having to stay longer in the hospital. So not being able to go home at the traditional 2-day time frame after delivery. And some of those common complications that we see in those kids would include respiratory issues where they may require some oxygen support, having difficulties maintaining blood sugars, usually having lower blood sugars. And then jaundice was another common thing because of liver immaturity. And then the final thing are things that are associated with neurologic immaturity, which would be not having quite the intact suck reflex, which can impact how the kiddo feeds. And so all those things certainly can prolong the baby's stay in the hospital. Then you have to weigh that, though, against, again, 8 to 10 years ago, that was common practice. And then there was this huge push for our national organization, the American College of Obstetricians and Gynecologists, to say, listen, we can't be electively delivering these patients at 37 weeks just because it's maybe convenient for the patient or for the physician's schedule. But rather, if you have an indication, then do it. And so there are a lot of indications that we will take into consideration when we are trying to make a decision, and if it's the right thing for a pregnancy to be delivered at 37, between that 37 to 40 week mark, that 37 to 39 week mark. And some of those indications are patients have pre-existing medical conditions, whether it be diabetes, hypertension. Those are two of the more common things that we see. We also have pregnancies that aren't complicated necessarily by a maternal issue, but rather by an actual fetal problem that we've seen. maybe it's a heart defect, and maybe it is a baby having difficulty with growth because of placental dysfunction happening in utero. And all of those things, those maternal pre-existing medical conditions and those fetal or placental related conditions that we see, result in an increased risk for stillbirth. And at that 37-week mark, we know that there can be a small risk for prematurity issues that we discussed, but we would rather take that risk of something that we'd consider to be transient, that the baby will more times than not grow out of, for lack of better terminology, and not have any permanent consequences from, versus taking the risk of a stillbirth.
So, Dr. Parrish, we just have a few moments left, so I want to ask you, if someone is pregnant or thinking of becoming pregnant, what would the most important thing be to take away from this when they're having a conversation with their doctor? When you came in this morning, I told you, I was an older mother giving birth, so my doctor said, as soon as you hit that 39-week mark, we're taking the baby.
Right.
So is 39 the new 40? Tell us exactly what all that means so that when a woman goes in and talks to her doctor, they're on the same page.
Yep. So briefly on the 39-week discussion, if you look at newborn outcomes at 39 weeks versus going to 40, 41 weeks, those kiddos are going to do just as well and experience the same risks for any potential newborn complication. So 39 versus 41, it doesn't make a difference. We start looking then at, like you said, advanced maternal age or other conditions, and we know that those can be associated with increased risk for stillbirth. So again, more benefit than risk to deliver at 39 weeks mark. What would be important for expecting mothers to consider, or I'm sorry, patients that are thinking of becoming pregnant and want to ensure the healthiest pregnancy outcome and trying to get to that 39+ week mark in the pregnancy, is having that conversation with their primary care physician or an OBGYN, just to do a quick overview of what their health history is, what medications they may be requiring. Weight is an important factor. Patients that are overweight are going to have increased risk for developing diabetes in pregnancy, insulin resistance. Patients have pre-existing hypertension. You want to make sure that that disease process is under good control, that they're on a safe medication that can be taken in pregnancy that's not going to have a negative impact on the development of the kiddo. So just having that conversation, making sure that there's nothing that they need to change in their lifestyle or medication regimen that could have a negative impact on their pregnancy outcome.
Dr. Parrish, it's always great to have you here to help us understand and better explain all this high-level stuff.
Yeah.
Good to see you.
Thank you, Jessica. Have a great day.
Thanks. You too. Well, when is a sore throat more than a sore throat? Here with us in studio is Terry Poole. She's a cancer survivor who had a persistent sore throat that just never went away. We are also joined by Dr. Andres Burr. Dr. Burr is a head and neck surgeon as well as the director of robotic and minimally invasive head and neck surgery here at the University of Kansas Health System. Good morning to you both.
Good morning. Thank you for the opportunity to be here this morning.
Well, and thank you both. And Terry, just ahead of time, thanks for sharing your story. What is it like to be reunited with Dr. Burr? I know he's a pretty special guy in your mind.
He is. I just feel so grateful. KU and Dr. Burr restored my hope. I was in a very fearful position when I came here, and I'm thankful, and it's all been a wonderful answer to prayer.
Well, good. We want to hear more about your story here in just a moment. But Dr. Burr, we want your help in just really understanding head and neck cancers overall. What parts of the head and neck are we talking about?
Sure. So as head and neck surgeons, we treat tumors, diseases of really every part of the head and neck except the eye and the brain. So this includes the mouth, the throat, the larynx or voice box, as well as the salivary glands. And we often are involved in treating advanced skin cancers.
So how is oral cancer different from head and neck cancer? I think they often get lumped into the same spot, but help us differentiate.
Yeah, oral cancer, mouth cancer, is a subset of head and neck cancer. So it's a type of head and neck cancer, but head and neck cancer is a much broader term.
So Terry, you learned you had cancer in 2021.
Yes.
But you told us that you had been feeling symptoms for quite a while before that time. What kind of symptoms were you feeling?
I felt tired all the time, and I had a persistent sore throat that never went away, and I had taken antibiotics many times, and it just didn't go away. And my right tonsil was actually 3 times the size of my left tonsil.
And did you feel that? But can you feel it? Did you? I mean, just once you went to the doctor, you knew that, but you knew that your tonsils were.
Oh yeah, I could open
tell.
my mouth and see it. Yeah. Yeah.
So does that sound pretty typical, Dr. Burr? Just these types of symptoms? And let's be honest, this time of year we're all coughing and hacking, and we feel kind of the persistent sore throat all the time.
Yeah. So Terry's presenting symptoms are actually unusual. So for the type of cancer that Terry had, the more typical and more common way of presenting is actually with a lump in the neck, and what that represents is a lymph node metastasis or spread of the cancer from the throat into one of the lymph nodes in the neck. But certainly, in differentiating these types of symptoms, sore throat from the common upper respiratory infection can be very difficult, because these symptoms are what we refer to as nonspecific. They don't really tell you exactly what the cause is. But in Terry's case, where even after antibiotics, the sore throat persisted, it didn't go away, she did the right thing in going to seek a medical opinion.
So when did you, this goes on and on and on, when did you decide to go see a doctor?
Well, this was actually about 3 years ago now. I had a tonsillectomy. I went to a facility that was close to my house.
So not us, you were somewhere else before us, okay.
Which was unfortunate. And I knew that on the one side I had the huge tonsil, and I asked the doctor, an ENT surgeon, is this unusual? I mean, do you think I have cancer? This doesn't seem right. And he said, no, you just need a tonsillectomy. I did not get a CT scan, no prior test before the surgery. They just removed my tonsils, and then found out 3 weeks later that I did have cancer. And then, they make you kind of fearful and send you to another cancer center, and they say, well, you're going to have radiation and chemo, and that's just the way it is, sorry. And I said to myself, this does not seem right. And my husband is a cancer survivor also, so we did a lot of research and found out about radical tonsillectomy. And so that seemed to be the way to go.
But I understand you had a surgery that wasn't necessary.
No, and my age, a tonsillectomy is pretty bad.
But Dr. Burr, what I like is that, and maybe it's because her husband had a cancer, so she was on high alert, but she was asking the right questions. Are you sure this isn't cancer? Are you sure there isn't more we need to look at? And then somebody says, no. This kind of brings up the whole reason we talk so much about the power of a second opinion. Sometimes we send people for second opinions, and sometimes they come here, and that's how you found Dr. Burr.
Yeah.
When you met with Terry, was it clear to you what was going on?
Yeah, but just to give a bit of background, overall head and neck cancers are not terribly common. We see them a lot here because this is the major academic center for the region. But overall, the average ENT or provider in the community within Kansas or Missouri is not going to see a lot of these. And so it's not surprising to me, the experience that Terry had. But yeah, once I saw Terry and we had the pathology available, we had gotten her a CT scan to continue to what we call stage her cancer. It was pretty clear that she needed additional treatment. And so when I saw her, we reviewed the options of surgery, which she ultimately elected for, versus radiation therapy.
When you first met with Dr. Burr, were you restored in your hope?
Yes.
Did you feel like I'm where I'm supposed to be?
Yeah, I just Dr. Burr and then his assistant Michelle really brought me back to hope.
Got you back. Okay, so then what was the treatment plan?
So based on what I saw, she'd had her tonsil removed. She didn't appear to have any lymph nodes involved, and so I thought she was an excellent candidate for what's called transoral robotic surgery, which is a minimally invasive approach to treat these types of cancers of the tonsil and the base of tongue.
So that was my next question. You can't use this robotic surgery on everyone, but in this case you could.
Correct. In select patients with these types of cancers, and primarily for HPV-related cancers like Terry's.
And no chemo or radiation?
That's right. That's right.
And what does that ultimately mean?
So ultimately, that means better outcomes, better quality of life.
Absolutely.
In terms of the side effects of head and neck radiation, particularly for these types of cancers, they can be quite severe.
Why are they rare? You mentioned rare. So what should we know about that as far as being able to detect or know when to go see a doctor?
So the biggest red flags, like Terry said, her persistent sore throat that just wouldn't go away. For oropharyngeal cancers, as I said earlier, the more common presenting symptom is a neck mass, and so a painless neck mass is a red flag, and that's something that should always concern viewers for a cancer. And then for oral cancers, actually the most common, or mouth cancers, the most common way that those present is with a lesion in the mouth, and so oftentimes it's not the patient but their dentist who detects an oral cancer.
Interesting. Yeah, that you would think that they would. Do we find that dentists find
Absolutely.
these cancers? They're kind of the first line of defense often.
That's right.
Getting down in there. Terry, you had to learn to swallow again?
Yes.
And you actually had a therapist who helped with this? What was that like?
It was amazing. I had a feeding tube for, I think it was like 6 weeks. And I had to, you know, when you get out of surgery for 2 weeks, you can't have anything by mouth. And then you start with a half a teaspoon of water, and you learn how to swallow that. And these therapists are amazing. They give you the exercises. I saw Dr. Burr and Emma, I think it was Emma.
Emma.
And, you know, they were just so encouraging. And I learned how to do these exercises, and now I can pretty much eat anything. It's just amazing.
Well, when I hear feeding tube, this does not sit well with you because you're kind of a self-proclaimed foodie.
Right.
And one of the goals for you was you wanted to eat a very fancy, expensive, over-the-top meal, champagne and all, in one of the most famous restaurants in California. And you did do that.
I did.
So tell us how you got to that goal. I know sticking with your therapy, but what did it mean to you to sit there and be able to do what you love doing, which is eat great food?
Well, we had a toast with champagne, and I thought of Dr. Burr because he said, after I came back, he said, "Did you get bubbles up your nose?" And I said, "No." But we toasted that, you know, I was able to do this. I didn't know, you know, you just don't know how long it's going to take, or.
And there you are doing it.
And there I am doing it.
And you shared some other photos with you and your husband. Just how instrumental has he been through this whole process? I mean, we talk about the patient, but the support is so important.
He was amazing. It was tough, you know. And he did things like he put pots of flowers out on our patio. He pulled up bird watching shows on TV that I could watch. And because it takes a while with the feeding tube. You're sitting there holding this tube up, you know, and it's kind of just a process where it drips down. And so, you know, it gets a little discouraging, but.
Well, he sounds like a keeper.
He is.
I think so.
He's my angel. We're both cancer survivors, and you know, and God's good. He gave me a wonderful spouse. So.
I love that.
Yeah.
So I want to talk about head and neck cancer and the causes. We talk about, Dr. Burr, tobacco, alcohol being risk factors. Then there's HPV, the human papillomavirus. Is it true that head and neck cancers are on the rise related to HPV, and just explain what that looks like and what it means?
Yeah, absolutely. So while we are seeing a decline in the overall number of head and neck cancers related to tobacco and alcohol, which we consider to be the traditional risk factors for head and neck cancer, at the same time we're seeing a rise in HPV, or human papillomavirus related oropharyngeal cancers, cancers of the tonsil and the base of tongue. And so that is the reasons for that aren't entirely clear. We don't know why we're seeing that rise, but it's been ongoing for several decades now.
And there's no way to test for HPV, correct, technically?
So there's, I think the more important issue for these types of cancers is that there's no way to screen for them.
Right.
So for cervical cancers, we have the Pap smear, which is an incredibly effective method of detecting precancerous changes of the cervix. We don't have anything similar for these HPV-related throat cancers, which are now actually more common than cervical cancers.
Do we see that on the horizon? Is that something that you dream about at night, hoping that when you wake up one day that's going to be a reality in your world?
I think you know, everyone who works in treats head and neck cancer patients would dream of some sort of way of detecting these types of cancers, but there are some real technical difficulties. I mean, these cancers affect a much larger area than those affected by cervical cancers, and they're areas that are very difficult to evaluate in an awake patient. Many of the changes that occur early on happen deep within the tonsil. They don't happen right on the surface. And so that makes surveillance or screening for these types of cancers very difficult.
So there's a medical term called unknown primary, meaning you know that there's a cancer, but you haven't been able to locate the original tumor. With head and neck cancer, I take it after what you just said, this is a challenge.
That's right. So about 90% of unknown primary carcinomas, carcinoma of unknown primary in the head and neck, are HPV related now. And so what our approach to these cancers, a patient comes in with a neck mass, we look in their throat, we don't see any clear primary tumor. Our approach to these is to obtain imaging and to obtain molecular testing on tissue samples from the lymph node in order to help better refine where that primary tumor is. And in most cases, it's somewhere in the throat and related to HPV.
So how does the treatment work if you aren't sure where the primary tumor is?
Yeah, that's a great question, and without getting too technical, we have really a stepwise approach of looking for that primary. There's extensive literature that's shown that if we can identify the primary, we can give less treatment, and patients' side effects and quality of life after treatment are better.
So be sure to ask your questions. You can use the chat on YouTube, Facebook, tweet us, or email the Medical News Network. Info is right there on your screen. Let's get our COVID count from Dr. Dana Hawkinson. Good morning.
Hi.
Hi, what you got there?
We got a little friend here.
I
so
do.
It's going to be a big week coming up.
It is kind of a big week, kind of a big deal.
Well, good luck to
Good luck
to the team and everybody traveling as well. So hopefully they come back.
Several of our doctors heading out to Vegas. So.
Yeah, and hopefully we can have a big parade again. So, but we'll see how it goes. Got a long week before that time. Right now in the health system, the COVID numbers are really about steady. We had 23 last week, 24 active inpatients this week, just a couple in the ICU. So holding steady. Maybe this is a plateau for a couple weeks or 2 weeks with 23, 24. Hopefully we can go down next week. Obviously, the lower the cases is always the better.
So Hawk, part of your job is implementing infection control measures like testing and masking and isolation like we saw during COVID. A new study published in Clinical Infectious Diseases that looked back at the pandemic and asked, did those infection control measures prevent COVID spreading inside hospitals? It sounds like it did, but how did this particular study prove it?
Yeah, I think this is good. I think this is one more piece saying that infection prevention measures do work, including masking. Just the same as we can continue to say that vaccination efforts continue to be safe and effective and save people against morbidity and mortality from whatever disease we may be talking about. In this particular study, they did look at healthcare facilities. They looked at healthcare workers using the infection prevention measures during pre-Omicron and post-Omicron or Omicron stages. So there were N95s, there were other mitigation strategies in there, such as good ventilation and everything that we used in the hospital. They were able to basically take virus samples from patients, but also healthcare workers who were sick, compare those two, compare all of the genomes, and what they found, particularly during the Omicron pandemic or wave, was that there was really no healthcare spread during that time. There were some patient-to-patient spread at that time, but comparing all those genomes, they were able to get really a good picture of who had what virus. And so what they did then conclude from that is that those mitigation strategies worked, especially masking. Now there was some time in there where healthcare facilities weren't masking as much and maybe went back to masking, and they did see some spread again there, again mostly related to patient-to-patient. They also noted that some things like ventilation, because one of the hospitals that they used was an older hospital, so ventilation wasn't as optimal as maybe in some of the newer design buildings. But overall, their conclusion was that yes, those mitigation strategies that we used in infection prevention, including masking, hand hygiene, the gowns, did actually help to prevent spread to and from healthcare workers, to and from patients.
What do you know? Everything you told us to do worked.
You know, it's working. I'm glad we have the black and white evidence, the peer-reviewed evidence to help show and support that. We know there is still a lot of misinformation out there, both about masking, about vaccines, about hand hygiene, what have you, but we know now this is one more piece again to support the use of infection prevention measures.
Hawk, I want to bring you into our conversation today because I think it goes without saying, you and I both as parents who have had our kids vaccinated for the HPV vaccine, that we really want, and you want parents to hear this conversation and make sure that they are getting their kids vaccinated for HPV. Tell us more, and what's your message to folks?
Yeah, I think it's so important. You know, these vaccines are so important. In particular, if we're talking about HPV vaccine, we have a vaccine against cancer now. This is what this is. It is a vaccine against cancer, and it works extremely well. Not only that, but is extremely safe and high safety profile. And if it's used in the correct setting, again, in the recommendations, the younger the people get it, the better, because at that point they have less chance of being exposed to those viruses, where you can have that immunity help protect you against the virus disease, but then also eventually against cancer. And so I think it is vitally important. We know that Missouri and Kansas vaccination rates with HPV vaccine are very low. So it is vitally important that if you do have children, to take them to their primary care doctors, to their pediatricians, get those recommended vaccines, especially the HPV vaccine. Again, just remember to yourself, it is a vaccine that protects people against cancer. It is a cancer vaccine.
Enough said.
Yeah.
Hawk, thank you so much. Let's get to some questions and comments from our viewers. First comments from one of our viewers, Judy. She said she recently recommended a friend to KU for a second opinion. They had previously been at MD Anderson, so we always appreciate a good referral, right?
Absolutely.
And just again, reminding people that second opinions, never be afraid to ask,
That's
right?
That's right.
Isabel wants to know, does Terry's throat feel different to her, or does it feel the same as before? Can you describe that?
Well, my throat feels pretty much the same. I need a lot of water sometimes to get food down. Mainly, I have to think more. You know, swallowing is kind of unconscious until you have a surgery or something like that. So, you know, I just have to think about it more, and honestly, I appreciate the ability to swallow more.
Yeah, it's the little things in life,
Yeah.
right? Cindy wants to know, does it make sense to have tonsils removed just to prevent getting a cancer in that area?
Yeah, it's a good question. No, the answer is no. You know, that when you kind of think about it at a population level, that means a lot of tonsillectomies, a lot of surgery, and surgery has risks. And in fact, the risk of anesthesia and tonsillectomy, although it's quite low, is still quite a bit higher than the risk of developing these types of rare cancers. You know, I do want to highlight Dr. Hawkinson's point about the importance of vaccination. Right. These cancers would go away if there were universal vaccination. We wouldn't, you know, we wouldn't have patients like Terry suffering from the consequences of treatment for these types of cancers if vaccination rates were higher.
Well, and just you sharing your story today, Terry, is exactly why you're just an example of why parents should be doing that. What are your thoughts and feelings about the idea that we have a vaccine so that some kid sitting there today, some teenager doesn't have to go through what you're going through?
Well, I'm just thanking God that we have that now, you know, and if they can avoid the suffering and you know, just not have to deal with that, you know, that's such a amazing thing.
It really is.
And one of the first things I did when I found out I had the cancer is I went to my church and I talked to the youth pastor and I said, make sure that kids know about the vaccine and the parents, you know, so that they can avoid this. It's amazing that we actually have a cancer vaccine.
Well, there is the perfect blend of faith and science that we talk about when it comes to medicine.
Right.
So, last quick question. Will wants to know, can safe sex prevent HPV-related head and neck cancers?
So yes, you know, if there is no contact, you know, between people during sex, then certainly that would prevent spread of HPV. But you know, that's not a plan for eradicating these types of tumors, especially when we have a vaccine available.
Not a realistic route.
Right.
Let's get people vaccinated.
That's right.
Let's also get our takeaways today. Dr. Burr, what do you want people to take away from this conversation?
So I think there are a few things. I think if something doesn't feel right, I think Terry's a testimony to that if something doesn't feel right, get a second opinion.
Right.
I think that if you know, one of the key takeaways from my standpoint is if you have a lump in your neck and it's painless and it's not going away, go get it checked out.
Come find you.
That's right.
All right.
Terry, what's the biggest takeaway from your story?
Just so thankful that, you know, I got back to hope through coming here to KU, and you know, thanking God for all the prayers and all the people who were pulling for me, and just keep the faith, take care of yourself, exercise, eat right, you know, and you know, be your own health advocate.
So glad you're back to living.
Oh, yeah.
And enjoying food and doing all the things that you love.
Loving it. Yes, thank you.
Thank you for sharing your story, and thank you both for being here today. Thanks to all of our viewers as well. We'll see you back here tomorrow. Coming up tomorrow on the Morning Medical Update, waiting for a new kidney zapped Amy Reinhardt's energy, but it never shook the 27-year-old's faith. I'm Jessica Lovell on the next Morning Medical Update, how Amy connected to a community of patients just like her and learned to endure life on the transplant list. Tuesday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcast. Now everywhere podcasts are available.